the light here is like I'm in a FBI interrogatory here. So Michael is also dedicated to work in the transient myelitis world, and he's going to give us an update about myelitis and rheumatological complications. That is a very important topic in the field of myelitis. Thank you so much.
Thank you very much for having me. Thank you for the introduction. I'll just start by saying that my own first experience with medicine was on the other side of the stethoscope, and so I was 20 years old when someone told me I had metastatic cancer and that maybe I could have kids someday, and here I am and I have 2 kids, and so I'm very happy to report that. Thank you. The next steps that I took were then, I went from culinary school to medical school at Mayo Clinic, and there I happened to be there right as they were really publishing the data on the aquaporin 4 antibody, and so I would hang around Vanda Lenin's lab looking at the microscopes and messing up people's experiments and things. And Owen Flanagan was an early influence in driving me into autoimmune neurology. I remember a time when we were on the wards and we were looking out the window at all the construction that was being done, and there were 10 or 15 construction workers down there with one guy with no shirt on in the middle of winter swinging a hammer, pounding this big spike into the ground, and everyone else was standing there watching him. And some of them were making fun of him, and I imagine some of them were criticizing what he was doing. And looking down with this huge team of doctors and medical students, he just happened to look up as I looked down at him, and I thought, we must look pretty much the same way. There's about 10 of us here, and the medical student, the poor medical student, is sweating and doing all the work that everyone else is criticizing. So, and that anecdote holds true in medicine even further than this. So I'm constantly teaching medical students and residents to treat gently our colleagues in primary care and pediatrics and emergency medicine. They are working in the pit. They are the man swinging the hammer, and it's very hard to do. They're humans, and they're busy, and they're tired, and they're working hard to help people, and sometimes they make mistakes. It's easy for us as the experts sitting back in the tower to look down and think how, oh, this is obviously transverse myelitis, and how easy that is in the light of retrospect. So please be gentle with your primary care doctors. They're working very hard to do what they do, and I have a lot of respect for what they do, emergency medicine as well. So anyway, now I'm in Billings Clinic. I'm an assistant professor of neurology at Rosalind Franklin University, and Sarah Qureshi and I are the 2 autoimmune neurologists there. So now we have a couple of us in Billings, Montana. Where? Billings, Montana, out in the middle of the mountains. It's lovely. So this is to briefly introduce, we'll talk about systemic autoimmune disease and myelitis. This is a sort of a view out the window, as it were, with a very high view on these. When I was asked to do this, I thought, there's no way I can talk about neurorheumatology in 30 minutes. And we said, well, let's just focus on myelitis only, and then let's trim that down to a few conditions. And I think that's doable. This is my son when we were at Vanderbilt for my residency, playing in the grass. He's so cute. I have no financial disclosures. I should probably have put on here that I have a bad sense of humor. That's probably a disclosure you should know. I also have very little original or creative thought to share with you. And everything that we use in autoimmune neurology is pretty much off-label, so just about anything that we talk about is off-label. This was the view out our apartment window when I was in Boston for my fellowship at MGH in Brigham, which was beautiful, but we spent our entire savings to do this. so I had to have a picture or 2 of it, and it was really nice at night too. Oh, that didn't come through quite right, I think. But so then we fled so that we could get some savings again and get back to living. This is William Osler, and so I bring this up to bring up a point that earlier in the conference we heard Dr. Greenberg talking about the importance of collaboration, and interinstitutional and interdepartmental collaboration is really a passion of mine and something I've always loved, and something that I love about neurorheumatology and autoimmune neurology in general. William Osler is probably one of the greatest gifts Canada ever gave us, and helped establish Johns Hopkins. So I think he would like this field because it's diagnostically very challenging and requires understanding of so many different conditions, and it requires this huge team of people to be working together, neuroinfectious disease, rheumatologists, neurologists, and so many more. And so I think it's important that we think about these conditions as a group together, and just like the shift in the name over to the new name, I think, reflects that. And it's important to know that the patterns of disease are different for these different neurorheumatologic conditions, and the treatment depends on the other underlying pathophysiology. So with that, we'll start in. Lupus, I think, is the first place I wanted to start. So this is a systemic autoimmune disorder which disproportionately affects women at about a 9-to-1 ratio. It's relatively common in the United States with about 50 and 100,000, and the incidence seems to be increasing. It's a clinical diagnosis that requires really the expert input of a rheumatologist. It's not something that you can diagnose just because a person has some symptoms or just because a lab test is positive. You really need a rheumatologist to help establish this diagnosis. The pathophysiology, as you can see, is very simple, not very complicated at all. There's a lot going on. We think that it boils down to defects in apoptotic clearance, which lead to intracellular antigen exposure, exposing these proteins that should not be seen by the immune system to immune system. And the immune system then dysfunctions, and we have hyperactivation of T cells and B cells, and antibody production and immune complex formation and deposition, which leads to the pathologic changes. Neuropsychiatric lupus is the term that we use to define neurologic involvement from lupus, and the incidence is highly variable, in large part probably because of a lack of standardized definitions and also some misattribution of neurologic manifestations to lupus. For example, lots of people have migraines and lots of people have lupus. The two are probably not related, but those numbers in some studies will drive the incidence of neuropsychiatric lupus up very high just because someone attributed the migraine to that person's lupus. On the other hand, stroke is much more common in people with lupus. Seizure disorders, movement disorders, demyelinating disease, including myelitis, can be seen, in peripheral neuropathy is another thing that can occur in lupus. So myelitis in lupus is relatively rare, estimated to affect some 1 or 2% of patients with lupus. And a very nice article from a group I think everyone knows at Johns Hopkins, including Julius Birnbaum, wrote this article some time ago about 2 different patterns of myelitis that seem to emerge in lupus, and this is held true in my experience. But I will say that the first pattern would be sort of a gray matter myelitis, and we've heard a lot about that today, as seen in acute flaccid myelitis. And the other pattern would be more of a white matter myelitis, as seen in multiple sclerosis and neuromyelitis optica spectrum disorders. But these clinical patterns are not absolute, and so there's some wiggle room in here where this doesn't always necessarily hold perfectly true. But it is a useful paradigm. So first, gray matter myelitis. The typical clinical pattern is a lower motor neuron disease. This is like acute flaccid myelitis. The reflexes are decreased rather than increased, and there's a flaccid paralysis rather than a spastic and stiff paralysis. In lupus, these patients often seem to present with a prodrome of fever and urinary retention, whereas that was not seen so much in the white matter myelitis. And disability after these, I apologize, the clinical course is really critical. As Dr. Pardo was talking about, that initial clinical story, which is so often missing when I'm looking at a case, and we always have to go back and review of the precise moment-by-moment symptoms that someone was developing, how things evolved, is really critically important. And in the gray matter myelitis, this is rapidly progressive over the course of hours and can be severe at deficits, whereas in the white matter myelitis, this tends to be more subacute over the course of days to a week or so. The CSF testing is also useful. In the gray matter myelitis of lupus, there tends to be a very high white blood cell count. There's often neutrophilic predominance, whereas white matter myelitis tends to have a mild pleocytosis, which is lymphocytic. And so these patterns are useful, but they're not definitive by any means. And on MRI, the spinal cord usually shows a lot of edema, and longitudinally extensive transverse myelitis is common in this gray matter condition. They seem to have a lower risk of relapse of the myelitis, but they're still high risk for other neuroimmune complications than the white matter myelitis patients. So I think it's best to look at some examples of this. So briefly, this is a 24-year-old woman who had lupus, and she developed a few days of bilateral lower extremity sensory changes, or paresthesias, which is a positive neurologic phenomena of pins and needles, kind of tingling and burning. Excuse me. And that evolved over a few days. Her brain MRI was unremarkable. Her spine MRI is shown here, and you see the big red arrow showing a little area of contrast enhancement up in the upper thoracic cord. And she had aquaporin 4 antibody testing, which was negative. She was treated with IV steroids and had complete resolution of her symptoms, and her immunotherapy for her lupus was transitioned over to rituximab, which has shown benefit, and she did great and hasn't had another episode yet. This is another example of white matter myelitis in lupus. That first is very similar to what you might see in multiple sclerosis. This is a 32-year-old woman, also with a known diagnosis of lupus, who developed several days of progressive weakness in all 4 extremities and eventually was unable to walk. And when she came to us, she had upgoing toes, which is a upper motor neuron sign. It's a hyperreflexia sign, again reflecting white matter myelitis. This is an abnormal pattern of dysfunction that we see referable to the white matter in the cervical, in the spinal cord. Her CSF was modestly inflamed with 77 white blood cells, was otherwise pretty unremarkable, and she was treated empirically on presentation with plasma exchange and IV methylprednisolone, in part because my perspective on this is that these patients should be treated like they have neuromyelitis optica, aquaporin 4 positive, urgently with very, very early plasma exchange and high-dose steroids. And her aquaporin 4 antibody eventually came back positive. So she has aquaporin 4 positive NMOSD in the setting of her lupus. The two coexist not infrequently. Unfortunately, she regained all function. She had a complete recovery with aggressive treatment, as we did, and she's still walking and doing well today. She's pregnant. So this is another example. So this is another example of the white matter myelitis that we can see, one pattern that we see in lupus. This one is more consistent, again, with the neuromyelitis optica spectrum disorders. And this is an interesting case because she does have skip lesions. These all occurred at the same time, and many of them were contrast enhancing, but you see these skipping along, which is unusual. This last case is a case of a gray matter myelitis in lupus. This was a 29-year-old man, again with a known diagnosis of lupus, and he was doing fine until he developed fevers, vomiting, diarrhea, and then had difficulty urinating. So this fits more for that gray matter myelitis case that I was talking about, or phenotype. And when you took the history on him, the course was rapidly progressive. He was admitted to the hospital for the fever and diarrhea, and then it was actually in the hospital that he suddenly became, well, or very rapidly became paralyzed. He developed weakness in the legs that rapidly ascended to his trunk, and by the time the morning came around, this was overnight, by the time I came on service in the morning, his arms were weak and he was having difficulty swallowing. He was starting to choke on liquids. And it's not shown here, but when we did get his MRI, this lesion extended all the way up into his medulla, so everything for him was at risk. So again, some basic lab studies that were useful here included that his complements were very low, quite low compared to his baseline. These are proteins involved in that complement cascade, which is the bullets that we talked about earlier, where the actual damage is being done. And his double-stranded DNA was elevated, which is seen in lupus activity. His CSF had a very high white blood cell count. This looks like an infection when you just look at the numbers. He had almost 3,000 white blood cells, almost all of which were neutrophils, which are typically bacteria-fighting cells. The protein was very high at 300. His glucose was very low at 15, and he did not have oligoclonal bands, but his IgG index was elevated, reflecting intrathecal inflammation. He was treated with broad-spectrum antimicrobials, but the infectious disease team and we felt that he probably did not actually have an infection causing this myelitis. It was too rapid, and we were very concerned about him. And so we actually did both broad-spectrum antimicrobials. This is a consultation between, again, neurology, neuroimmunology, neurorheumatology, neuroinfectious disease, primary care. There was probably 30 people caring for this man. And so he got broad-spectrum antimicrobials, and we did plasma exchange and IV methylprednisolone and cyclophosphamide. And nothing ever grew from his cultures, which were obtained before the antibiotics were given. But he fortunately did really well. Ultimately, he was not able to walk at discharge, and I still tend to feel pretty bad about that he had to go through all of this. And I have to remind myself that, but he could swallow and he could use his arms, and that's because of this huge team of people working hard and staying up late and coming in early to take care of this man. And he ultimately did really well. It turned out that he did have norovirus, was the cause of his diarrhea, and we even checked his CSF just to see if it was in there, and it was not. So there was no norovirus in his CSF, which would not be expected to be found. But he actually did very well considering how very dangerous this circumstance was for this man. So for lupus myelitis, again, there is no one-size-fits-all treatment for any of these conditions, but in general, IV steroids, often in combination with cyclophosphamide, seem to be a little bit better. And depending on the underlying phenotype, plasma exchange, rituximab seems to be beneficial. IVIG, there's some anecdotal reports and may be helpful. And especially for the gray matter myelitis, it's important to consider infectious causes, and broad-spectrum antimicrobials are often given in tandem with immunotherapy. Next on our list is sarcoidosis. This is one of my personal favorite conditions to study. I call it the honey badger of the immune system, because it does whatever it wants, so to speak. This is also a systemic autoimmune disorder characterized by a granulomatous inflammation, where they form these little pockets of granulomas, which is a particular type of inflammation. And in this condition, a particular protein called the tumor necrosis factor is very important in the pathogenesis. It most commonly affects the lungs, eyes, skin. The liver can be affected not infrequently, lymph nodes, and the nervous system, which historically we think of as being in some 10 or 15% of people while they're alive, and maybe another 10% identified post-mortem on biopsy, et cetera, or on autopsy, I mean. But actually, more recent studies focused on neurologic complications show higher incidence, somewhere in the range of maybe as much as 34% of patients, although these are limited data. So neurosarcoidosis, when it does occur, when sarcoid affects the nervous system, can cause a number of different patterns. The most common of these is a cranial neuropathy, aseptic meningitis, especially leptomeningeal contrast enhancement is a common pattern. And they can also affect the brain, producing seizures or mass-like lesions, or that appear mass-like. Vascular disease occurs rarely. And a small fiber peripheral neuropathy is not infrequently encountered. And myelopathy is seen in some 5 to 26% of patients. Again, the higher numbers are the more recent data that have been reported. This was historically thought to be very rare in sarcoid, but actually seems to happen with some frequency. Sarcoid myelitis, again, it's the honey badger of the immune system, so it does kind of whatever it wants. It can produce a number of different patterns, but there are some distinct profiles that we see. It's typically a subacute progressive myelitis, oftentimes longitudinally extensive, which was seen in 75% in one study. And this has to be distinguished from other immune-mediated myelitis and myelopathies, vascular included, as Dr. Pardo outlined, because the treatment is different. And in particular, with multiple sclerosis and possibly with NMO, tumor necrosis factor antagonism is a bad idea. It seems to worsen MS, whereas it's one of our mainstays for severe sarcoid. So this is a critical distinction to make. This is one example of a patient with a cervical myelitis who has a longitudinally extensive myelitis with a short area of contrast enhancement. This was biopsy-proven neurosarcoid. Other MRI features. So some MRI features can be useful and can help us to distinguish these. In particular, Owen Flanagan at Mayo described a few patterns. One where we see this central canal and or dorsal subpial contrast enhancement. There's some subpial enhancement here. You see these arrowheads, this little bit of brightness going down the back of the spinal cord is subpial contrast enhancement. So that's a pattern, especially when it's long. And contrast enhancement that persists for several months despite therapy is another clue to neurosarcoidosis. Finally, a nodular radiculomyelitis can be seen. This can mimic what we call the Ellsberg syndrome, which is a viral infection of the lower spinal cord and conus medullaris, as well as the cauda equina, or horse's tail, which are these nerve roots coming out. But here you see in neurosarcoid, you see this nodular leptomeningeal enhancement. This is all contrast enhancement that shouldn't be showing up like that. And that's another typical pattern that we identify. The CSF is typically pretty benign looking, mild to moderate lymphocytic pleocytosis. The protein might be a little high. Low glucose or hypoglycemia is infrequently seen, but when it is seen, it can be a clue to neurosarcoid, so we use that. And oligoclonal bands or an elevated Ig index can be seen in some patients as well. So none of these findings are sensitive nor specific for sarcoid myelitis. Oftentimes we talk about a CSF ACE level. which is angiotensin converting enzyme. It does not appear to be very sensitive or specific for sarcoid. That said, does it still oftentimes get sent? Yes, and it can be kind of helpful in the diagnosis, but in general, the data have not supported that. This is an example of myelitis in sarcoid, which has this punctate appearance, almost like a vasculitis of the spinal cord, but was a sarcoid vascular involvement in the cord. So important in the diagnosis of sarcoidosis is to, oftentimes these patients present and they don't have a diagnosis of sarcoid. They just come in with myelitis, and it's up to the neurologist to help identify that sarcoid is the underlying cause. And so we're often doing evaluation, the history and physical exam, again, as Dr. Pardo outlined, is critically important, looking for clues to other diagnoses. Skin and eye examination is valuable. Oftentimes we'll find a little sarcoid on someone's skin that's easily biopsied, or hilar lymphadenopathy in the chest, or pulmonary lymphadenopathy seen on chest X-ray or CT. And sometimes we go to PET scans, which are combined with CT and show metabolically active areas that can be targeted for biopsy as well. That biopsy is critical in establishing the diagnosis, and does not always have to be a CNS biopsy. So there are different categories of possible, probable, and definite neurosarcoid depending on where the tissue was obtained. But this is ultimately really a tissue diagnosis. We have to get tissue from somewhere to affirm that it's sarcoid. So the treatment here, the mainstay, sarcoid responds really nicely to glucocorticoids like IV methylprednisolone or even oral prednisone if someone's minimally affected. So that's really the foundational treatment. And then you might use immunotherapy, with ongoing immunosuppression. Methotrexate and mycophenolate mofetil seem to have the best data behind them, but azathioprine is also used. And then for patients who are really severely affected or who are recalcitrant to these other treatments, then tumor necrosis factor antagonism is valuable, so we use infliximab for the most part here, and there's a dosing regimen for that. This is in Boston at Memorial Day. Actually, this is at the Soldiers and Sailors Memorial, and they set up over 37,000 flags are there, and there's one flag for every member of the Massachusetts who died in a war for the United States, going all the way back to the Revolutionary War, which is pretty amazing. So this is my son poking one into the ground there. So we did a study that was this huge, speaking of collaboration, this huge collaborative study between Vanderbilt, Mass General, UCSF, University of Kansas, and a number of other centers where it happened that Jeff Gelfand out at UCSF and I both had this idea that we should publish a series of our patients with recalcitrant neurosarcoid for whom infliximab was used. And I started reaching out to all these other centers, and then Jeff and I bumped into each other, and he's been a great mentor of mine ever since. And so we co-first authored this paper on infliximab for the treatment of CNS sarcoid, a large series that was published here. There's also a large series from France that showed some benefit. And so oftentimes we're operating outside of really strict evidence-based medicine. As Dr. Levy was talking earlier, there's not a lot of evidence-based medicine that, there's never been a placebo-controlled trial for rituximab, for example, for NMO, but we see that it works. And I always joke that evidence-based medicine is very valuable and important, but so is experience-based medicine. And for example, there's never been a placebo-controlled trial of parachutes for people jumping out of airplanes either, but it works. So next we'll talk just briefly on Sjogren syndrome. This one we might skip a little because I can take you right to the punchline, but this is a lymphocytic infiltrative disease where predominantly women and predominantly around 50 years or above will get this. But just important to note that many people have dry eyes and dry mouth, two of the main presenting symptoms of Sjogren's. That's usually related to medications and aging and a number of other things that can come in, so don't panic. But when we do have it biopsy confirmed and or confirmed by a rheumatologist, there are some neurologic complications that we see, especially neuropathy, small fiber neuropathies, but myelitis has also been described. Here, the punchline is quick because the vast majority of patients with Sjogren syndrome who develop myelitis have coexisting aquaporin 4 positive NMOSD. So these patients are generally treated as though they have NMOSD, and that seems to be the best course. And most of them do have the antibody positive. There are a few who do not. Finally, Behçet's disease, which I think is really a fascinating systemic rheumatologic condition. This is a map of the Silk Road, the ancient Silk Road. And Behçet's disease has a strong genetic predisposition in people who are descended from country along the ancient Silk Road. So the highest incidence is seen in people from Turkey, people from Iran, and people from Japan. But that route goes all the way through to the Mediterranean, as you can see here, Northern Africa, et cetera. So those are the patients we think of as at risk, but that oftentimes is very hard to know because here, everyone has a little bit of everything in them. So, but this is a systemic inflammatory condition characterized by recurrent episodes of predominantly mucocutaneous ulceration, so ulcers on the mouth, uveitis, inflammation of the eye, oral and genital ulcers. And the genital ulcers are very painful and tend to occur on the scrotum or the labia. So this is a very distinct characteristic. And patients are often, I have to warn them when I'm starting to talk about this as a diagnostic possibility. Why am I about to ask you about scrotal ulcers? Because it seems completely irrelevant to a person who's coming in with weakness in their legs, for example. And the reason is because, we may be looking for evidence of one of these systemic rheumatologic conditions. So don't be too offended if we ask. And then recurrent episodes of arthritis. The incidence is equal in men and women, but men do tend to be more severely affected with Behçet's than with other autoimmune diseases, which is a little backwards from what we usually tend to think. And it's characterized by this arterial and venous perivascular infiltration by T cells, B cells, and neutrophils. And there's a number of inflammatory cytokines or proteins that are also involved in Behçet's disease, including, once again, the tumor necrosis factor. So neuro-Behçet's occurs in about 10% of patients. And this neuro-Behçet's is actually much more common in men than in women, but can occur in both genders. And we divide this into parenchymal and non-parenchymal neuro-Behçet's. So parenchymal Behçet's is what we'll focus on here. And that predominantly includes this brainstem encephalitis. So you see this is an MRI of a patient with this is the pons, which is Latin for bridge, because it's like a little bridge over the river of CSF beneath it. And it's inflamed. You see all the brightness. And on the contrasted images, there's contrast enhancement. This is a typical MRI from a patient with neuro-Behçet's with brainstem encephalitis. But also the meninges, cranial nerves, white matter, cortex, and uncommonly the spinal cord can be involved. So again, here these patterns of both MRI and CSF profile are important for us in helping to lead us in a diagnostic direction, but again are not specific, nor are they sensitive per se. But CSF tends to show a modest pleocytosis, meaning a modest elevation in the white blood cells. That's usually a combination of neutrophils and lymphocytes. The protein is usually elevated, glucose is typically normal, and very rarely do we see oligoclonal bands in neuro-Behçet's. MRI will often demonstrate, depending on the localization, can demonstrate this brainstem encephalitis, which classically is described to spare the red nucleus, which is this little part of the brainstem here. So this is a good example. You see all this bright white stuff, but the red nucleus is relatively spared, some of which is imaging, but it also does seem to be less affected on pathology. There may be little areas of hemorrhage in there because it's not a true vasculitis, but it's a relative of vasculitis. It's similar, so it may bleed a little bit. And these may enhance during relapses, but typically don't have a whole lot of enhancement associated with them. For neuro-Behçet's disease, myelitis is uncommon, 3 to 30% or so of patients with neuro-Behçet's, which again is maybe 10% of all those patients. And it rarely occurs in isolation. I can think of one case that I had with Dr. Venna at MGH that had myelitis, and we eventually found that he did indeed have Behçet's. When it does affect the spinal cord, it tends to be more often cervical, followed by thoracic, and it's often longitudinally extensive. This is a child patient of mine who had Behçet's in the brainstem. You see in the lateral medulla here. And he also had upper cervical cord myelitis, and he did well with treatment. So the treatment of neuro-Behçet's disease, I hate algorithms in medicine because I think it's an excuse not to think, but this one actually works pretty well, I think, is a nice escalation approach to treatment depending on the presentation. But IV steroids, again, are very useful. And then these can be tapered. If a patient does really well, they can do oral steroids for some time and then eventually taper. Depending on how they do, they may need disease-modifying therapy with, again, azathioprine, methotrexate, cyclophosphamide being the primary medications that we use in this setting. And then for patients with a severe presentation or for recalcitrant Behçet's disease, we may again use the tumor necrosis factor inhibitors. So just a thank you to some of my mentors along the way, especially Sid Pawadi, Gopal Venna, Shamik Bhattacharya out at Brigham and Women's, and Tracy Cho at MGH, who's now at Iowa, Jeff Gelfand, Elliot Froman, and Arun Venkatesan, people who have really helped me along the way, especially in neurorheumatology. And a couple of nice references. There's a great article that this guy named Benjamin Greenberg and Elliot Froman wrote. I'm not sure who they are, but it was a very nice article. This has a nice review. It's a little ancient at this point because I think it was 2013, which is almost prehistoric for neuroimmunology, but still a great reference article. And Tracy Cho and Shamik Bhattacharya, Simon Helfgott at Brigham and Women's just put out this neurorheumatology book. Colleagues of mine and I wrote the Sarcoid chapter. That book is out. It's very good. It has really top-notch experts in it. I would guess that there's some of the other people in the room are in this book as well. And Sara Qureshi and I practiced together out in Billings Clinic, as I said, and she wanted to be here, of course, but she broke her leg climbing to the base camp of K2, and she's doing great. She said to say hi to everyone and that she misses everyone, and that she's starting to sort of slowly recover. But she always jokes that her patients, because I started out at Billings Clinic last year, and her patients see this picture and they say, "Who's this giant standing next to you?" So I have a couple minutes maybe for questions.